co-creating culturally safe and humble primary health care definitely touches near and dear to my heart. And I think we need to do better at educating and implementing the Truth and Reconciliation calls to action, as well as the principles outlined in the UN Declaration of the Rights of Indigenous Peoples in Canada. And if you don't know what either of those two things are, I really encourage you to take out your phone right now and Google them. And so I think those need to be the embedded principles and guidelines, because reconciliation needs to be defined by Indigenous people. And so from there, I think we can start moving on some strategic priorities around the area, including supporting a community-led, culturally safe care to help build bridges between the healthcare system and local First Nations communities, like what they're doing in Fort St. James. I also think that we could do better at addressing social determinants of health, which will help to improve the health of Indigenous people, but also other marginalized groups, including addressing poverty, homelessness, and trauma, just to name a few.
James, spent all my career in remote rural underserviced practice. When we started in Fort St. James 7 years ago, we recognized that there was a big gap in the quality of services that is received by First Nation partners in our area. As a whole, in any event, access to care from remote communities is different than it is for urban communities. Understanding that there's that difference created an opportunity for us to sit down with our First Nation partners and start a conversation around how can we improve care. And that led us to the understanding and the respect to know that the only success will be if it's community needs driven. And if the patient stays in the center of the care and we listen to what people tell us and then see what is something that can be built around their culture and their values. That created a safe space where immediately culture, humility and cultural safety became part of that integral process to design a healthcare system around a population need, and not just from a system-based perspective. So we were very fortunate that our First Nation partners supported us unconditionally to work towards getting design of how we can shape a care model and how we can change the care model, where we ultimately was able to work with Northern Health as a health authority, the Ministry of Health, the community as partners, and the care providers to slowly and incrementally begin to build a health system where we now went from one physician in 2012 to 8 physicians in 2018. And we were lucky that we were the recipient of the first 2 physicians of the new physician initiative to be applied solely for First Nation healthcare. And that brings us now to a place where we've lived this story and we've been on this journey to respect each other as partners with First Nations, to know what we can bring to the table, know what their needs are. They have found their voice to tell us how we can do things differently, that we are now working towards creating a cultural wellness workshop that is community designed and will be applied to try to improve the way that physicians and health practitioners view cultural sensitivity and cultural wellness in the way that our First Nation partners want us to see what safety, humility and trauma-informed practice and care actually should look like. And we are very blessed. On the 1st and the 2nd of February, we will have the first cultural wellness workshop, which we call a caring circle, in the community of Fort St. James, where First Nation partners and First Nation Health Authority, our Northern Health partner, our Northern Interior Rural Division partner, RCCBC, as well as UBC CPD, all coming together with supports from Doctors of BC and the Ministry of Health to deliver a cultural wellness workshop where we will show in a clear, practical fashion how we were able to walk the talk of designing something that is meaningful and that is touching so many lives in a manner that our First Nation partners have never received care before. Blessing to be involved in this. This 2-day workshop has enlightened me to know that it is not just in the small places where people toil away very hard to do an honest job every day to affect and improve the health of people and the people that we care for, but that our government partners and that medical leaders from various pockets of health delivery in the province all came together to try to make a difference. And it enthusiasms me that this is possible to effect change in a manner like this. Thank you.
We have a crisis in British Columbia. We have patients that can't get a family doctor. In a developed country like Canada, there is no reason that you should not be able to have a family doctor. So what's happening? What are the doctors doing that they can't take on more patients? They are filling up their days with work that could be done by others. For example, I don't need to be the social worker, the physio, the counselor, the dietitian. I need to be the doctor. I need to do the diagnosis. I need to do the treatment plan. I need to do things that doctors do. But I need a team. I need a social worker. I need a physio. I need a dietitian. I need a counselor so that the patients can get the services they need without me trying to pitch in and try and do the best I can when I'm not trained to do those jobs. That would also free me up to see other patients, and that would improve access, and it would improve attachment for patients getting a family doctor.
For me, I'm very excited about the possibility for team-based care because I think that the needs in our communities are growing much faster than we can deal with them individually. And so it's important that we have everyone working together, that we're hearing all of the voices, and that we're all able to work to the scope of our practice, doctors, nurses, other allied healthcare professionals, so that we can meet patients where they are. We can keep them at home longer, we can prevent health, we can find out what it is that they need. And so by working together, by having a new system, we'll be able to meet the challenges together.
Primary care teams, absolutely. So I originally wanted to go into medicine. I was encouraged to go into medicine because I was talking about a dream when I was in my previous undergrad program about developing interdisciplinary teams that would go to remote, rural First Nations communities and provide care on a regular basis, understanding that some of these communities are very tiny and couldn't sustain full-time professionals, but they could, a group of communities could, and so we could go to, say, Stella on Monday and Notley on Tuesday, and with Carey's County Family Services, I do go out into communities and on a regular basis, and I follow up with virtual medicine, and I work with some healthcare providers like drug and on-call workers and mental health clinicians and MOAs. But even still, we work very much in isolation because there's so few resources that most of the time we need to be spread out to try to cover as many communities as possible, which does still create some fragmentation because we're not really working together. And so for me, I would love to have a more synthesized approach. I would love to have somebody who is more culturally embedded, either a healer or an elder that I work closely with, or having somebody who's trained as a very top level MOA or LPN or something like that, so that they could help me get patients going so I can see more. So starting some chart notes, doing some vitals, but also helping with follow-up and coordinating care after I see them to make sure they can go get the labs, or that they know how the process of booking their appointment for a referral to a specialist, or those sorts of things to help people navigate the system, because the system is very complex and a lot of people from rural, remote places would find it hard to know how to navigate a trip to Vancouver to go to VGH or St. Paul's, and so having those kind of community outreach workers or patient navigators, I think would be so helpful. And I think with the physicians and carers at Canny, there's now 10 of us, and we've worked really hard at building our relationships. And so I think we're at the point where we can help to invite more healthcare providers, so we can get to the point where we're not just putting out fires, but actually building up the health and resilience of Indigenous people by better and more adequate healthcare teams.
We talk about teams, but we need to make sure that that team includes the family, the patient, the non-paid caregivers. I have a mother who's soon going to be 97 who needs to go into care. I have been providing assisted living for her along with my sister, but she's no longer safe at home. I've had firsthand experience with the system, and I know that there needs to be more of a voice from the family and the patient.
The thing that I'd like to bring as a story would be my wife's journey in the healthcare system, and fundamentally how there was a determination early on of something possibly being wrong with her heart, but wasn't certain what it was and if in fact it was anything that we should be alarmed by. Over time, we had to take actions on our own to lessen her workload, and so she stopped working. We moved over to Gabriel, and over time we watched things progress. In the meantime, all through this time, roughly 20 years, she's gone through a number of specialists, and the results kept coming back ambiguous or certain to the degree that it wasn't her heart. Long story short, a number of things were missed, and while she is not a typical case, they shouldn't have been missed, as we now know. And had there been a team in place, rather than individuals, it would have been caught much earlier. We ended up in Toronto in a team-based environment that within 3.5 days got us a resolution, using all the clues that were in fact available within much of the work that had been done. And following open heart surgery, she is effectively, as far as her heart is concerned, perfect. So a team-based environment is really what we need in BC, and we don't have it. We have, in point of fact, lots of silos with excellent people who don't have the time of day to actually engage in broader thinking on any one patient, but to see that patient in the context of the things that are expert to themselves, that they're excellent in. And if you fall within a certain category of patients that show up as having a thing that they can do something about, brilliant. If you don't, and you're missed because you're on certain margins and again, a lack of a team-based approach, you keep bouncing around the system. And in my wife's case, just to end it on a charming note, she looked down at herself that evening, post-surgery, and she said, well, looking down at the mouth, she said, I always wanted cleavage. And that was end of a good story. But hence my remarks about the fact that we do need to get out of our geographic and health authority-based silos and move into something that makes a lot more common sense.
And I work for UBC Health, and for the last 10 years at least, I've been working to promote team-based models of care across the province. And it's really only been in the last year that the need for that and the importance of team-based care, particularly in our primary care context, has been highlighted for me. There was a young man who I knew, and he did not have a family doctor and was having some health problems. And he was trying to deal with these through walk-in clinics. And he finally got attached to a family practice and was diagnosed with cancer. And we talk a lot about attachment and the need for people to be attached to healthcare providers. And this young man, he was then connected with a team of amazing healthcare providers that he started to complain had no idea what they were doing and what they were talking about. And really, this really affected his trust in his team and the system as a whole. And he said, none of these people know what they're talking about. I'm going to stop treatment. And in talking to him and based on the lens that I come from and working around supporting primary care teams, I realized this was not an issue of healthcare providers that didn't know what they were talking about. They were all very competent healthcare providers in their own disciplines and their own professions. What it was is a situation of a team that wasn't actually practicing as a team. They weren't communicating, they weren't sharing information, they were giving him different messages, and that really impacted his care. Luckily, I was able to point that out to him, and he did continue on with treatment, and he's doing well today. But for me, that's the story that tells us that it's not enough that we attach people to healthcare teams, that they have access to healthcare providers, but that they have access to teams that are functioning as a team and working together truly collaboratively.
I'm a family physician in Nelson, BC, and I work in a collaborative maternity care clinic there. And I also work with the Rural Coordination Center as one of the leads with the Rural Obstetrics Network. And around the ideas of team-based care, where team-based care is really going to be influential in regards to providing care to a community, is when there's a collective sense of responsibility from everybody involved in the team to care appropriately and well and very with good intention for the entirety of the group of people that you're in service to. And that really is only going to happen when you're also reflective and honest with each other to take care of each other. We are all medicine for each other, and when we're able to bring down those barriers and have flexibility and adaptability in how we approach care in a very family-based and family-centered way, that's when we're really going to be able to rise to provide integral care to everybody involved.
I like to talk about designing, planning, and implementing team-based care. And I wonder, in a system of care, how is it possible not to think about the role of the family caregiver in terms of who's on the team? So let's just take a look at a triad of care. You have the patient, the provider, and the caregiver. They provide 80% of the care. And yet, until very recently, they're typically not included in any conversations around who's on the team. So when we design this new future that we're excited to be considering, let's think about team-based care. Who's on the team? With family caregivers providing 80% of the care, they are on the team. Let's think about that.
I've been working in the area of healthcare education for over 10 years and really working to promote collaborative practice in team-based care models. And I've really never seen the type of momentum and commitment that we have today that's really been demonstrated at this meeting, and in terms of the number of partners that have come together and are actually talking about team-based care in a real way, in a way that's going to help improve the care that British Columbians receive.
So the one thing I've learned in my 29-year career practicing rural generalist medicine is I may bring the expertise and knowledge into the domain of medicine, but by no means am I the expert in managing patients. Patients know what they need and they know what they deserve, and I really believe that having patients and communities, citizens, as partners in helping appreciate where the gaps are in their own individual community, within their region, or possibly within their own journey in healthcare. I think it's really important that we take a step back, consider those needs, and sit down, remove the assumption that there's a power struggle around how we design healthcare services for communities and regions, and have the partners willingly agree upon what services are necessary. Then and only then do I believe that we're going to address the needs of underserved, impoverished citizens and communities, and truly uplift the well-being of citizens throughout British Columbia. That's my thoughts, that's my message.
Hi, I'm Robin Rutledge, and I'm a psychiatrist in Duncan, BC. But this story starts when I was 21 years old, and I'm a student nurse on night shift second year, and I'm with 35 men who've been there for most of their adult lives. And I'm the only staff there because that's how we were staffed. So it's 2 o'clock in the morning, I've got this little pool of light, and this guy comes out of the dark and he's been looking for me and he's gonna hurt me. But behind him all of a sudden looms this huge man, Tiny we called him. And he said, "What are you doing?" to this guy. And the guy says, "Nothing." He says, "Go back to bed." So there I was, scared and then saved. And I thought, oh, I thought I was alone, but I'm not alone. And that's my point. We're not alone. So what I want to know is, how can we now reach out to our public, the people, and join with them, have them join with us to create wellness and health? That's our question. That's what we have to do. That's the third wave of the IHI. And so I want Tiny to come out of my past and help me remember that the people that we're working for are the ones who are going to lead us into a healthy and well society.
So I think this is really important. And again, bringing it back to an Indigenous lens, I think we need to start having a healthcare system at all levels be driven by community members. And in large part because we are community members ourselves as providers, that does include us. But we have to be starting to collect data and metrics and then acting on them from patients. So every single time a patient gets a prescription filled, goes into the hospital, sees their family doctor, they should have a little, even a one question survey about like, how was this care for you? How could we have done better? What did you especially like? And have a commitment from all levels of the healthcare system that we are going to act on major themes that come from that data collection and feed that back to the public so that they know we're acting on the data that we're getting. I think we all, and myself included, really like to think that we know what's best, but our whole point of being here is to improve the health of British Columbians in all facets, in all areas of the province. And I think because we're not asking continuously, a lot of times, yeah, we have data from the public, but it's 6 years old. And so the needs and wants may have changed by now. And so we need to be better at collecting it in a timely manner and acting on it. And therefore we need people like data analysts and I don't even know who else because I know so little about this, but we need more people to be able to collect it, analyze it, and feed it back in a timely manner.
Often in healthcare, we talk about accountability, and we think we have to develop structures that we're accountable up to an organization, but really we're accountable to each other and to the people that we serve and work with. So if we could bring people together as they're planning so that we're accountable to each other, and as we look at our successes and look at ways that we can improve, that we come together with providers, with administrators, with community members, and we can talk and have dialogue and work together and be accountable to that, I think it'll work. There's an opportunity for us to change the way we plan and meet the needs of the communities. I think we have a lot of wisdom that's here, and I think there's the opportunity to build on that and start to hold when we talk about that accountability piece, rather than just coming together and putting things on a piece of paper and walking away and thinking that somebody else is going to take that ball and run. That, as we say, there is no system, you are the system. We all need to take some responsibility, especially those of us that are being paid to do this work and have the honor of being in positions of privilege, that we need to respect that and contribute in the best ways that we can.
I think including patients and community members, citizens in the transformation process of healthcare is integral. How do we do that effectively? How do we get people who are in the system to be part of that decision-making process? I don't totally know the answer, but I think that to have practitioners and policymakers and administrators truly understand what it's like to be a patient will help that process, because I think it changes the way you make decisions. When you understand what it's like to be that person in the bed or in the wheelchair, or going through the system from different provider to different provider, and having, trying to have that care kind of wrapped around you to understand what's really going on. So I think that it's one of the fundamental things that we need to do first and foremost, is really get engaged people being part of this transformation.
The First Nations Health Authority is a health authority by First Nations people for First Nations people. And First Nations people are not just a series of communities who have a stake in healthcare. We have our own health authority. We are one of the founding nations and have a distinct status in Canada. We have the worst outcomes of any ethnic group in the country, and we have rights and title as protected by the Constitution as the original inhabitants of this land. And the First Nations Health Authority is really a self-determining step where we have said we have skin in the game. These are our members. We look after them and we help with the work of health. And so one of the messages that I've been trying to bring to today is First Nations will be at the table as we transform the healthcare system in BC. So I hear from First Nations patients a lot. One of my most memorable experiences was when a baby had died, and we were speaking to coroners about the timely return of that infant body back to the village, to the family. And the coroner was explaining what their rights were by law, the BC Coroners Act. And our chief said, we know you think you're in charge, but we think that's our baby. And it really reminded me that these are our bodies, these are our children. We have to have a place at the table, we have to have a say. And I think that's the case for all patients. And sometimes when we're looking at the healthcare system, we make the healthcare workers the star of the show. And I just disagree with that. Anyway, I do think that improvement in the healthcare system actually has to place the community at the center, not just have the patient voice, but put communities at center. And we as physicians and clinicians have to, I think sometimes physicians and clinicians think only of healthcare as happening in their offices or in their hospitals, and my focus is very much about care in the community. Communities are looking after themselves. We are health partners, not the center of healthcare. So how do we adjust what we do and know so that we're situated perfectly in community? I think that's the work.
So this has been a very exciting time at this providers conference. It's been great to hear all the different ideas as to how we can improve the healthcare system. As co-chair of the GP Services Committee for the Doctors of BC, I'm so privileged to be involved in this work. So just to give people an overview, what are we trying to do? We are trying to make sure that the citizens of British Columbia have access to health care when they need it. They have a family doctor that they can call their own. And we're trying to integrate all the services that are just silos right now. So where do people go when they want health care? They go to their family doctor's office. So one of the things we're doing with the patient medical home is we're trying to upgrade the family doctor's office to be more than what patients would get at a walk-in clinic. We want there to be continuity of care, coordination, comprehensiveness. We want to have a team of doctors that you don't have to provide every service, but as a team you can give those services that are needed in the community. And then we can take the various doctors and their patient medical homes and connect them to other patient medical homes. So again, the services can be broader. And then we want to add in the allied health providers. And that's where the primary care network comes in. There's many of these allied health providers that provide services that are coordinated by the health authorities. Think of the patient at the center of a concentric circle, patient and their family. And then think of the patient medical home wrapped around the patient. And then wrapped around the patient medical home is this primary care network with our system of providers, our team-based care. And then we have connections to our community specialists because so many of our patients are having their healthcare needs met in the family doctor's office, in the patient medical home. But many of our complex patients have regular connections to specialists, so we need them involved in this whole system as well. We need to have connections to residential care. We need to have connections to the acute care hospital. So this is a whole target operating model that we talk about, but it's trying to get rid of the silos, have the family doctor's office or the patient medical home, as we're calling it, as the foundational unit, everything else wrapped around it, and coordination will actually happen from there. Patients will go out and come back, but somebody will actually have all the information. The patient will know where to go when they need help and if they need other services. So it's a great vision that we have, but are the patients, are the citizens in British Columbia understanding what we're trying to do? We want to make sure that there's longitudinal care, that there's a relationship with their doctor and with the rest of the team. So bear with us, it's taking time. We're moving a little bit at a time, but this is not a project. This is a transformation. This is how the system is going to be into the future.
I've been a rural practitioner in Clearwater, which is north of Kamloops, for almost 30 years in June. I think one of the things I like to think about is the vision statement of the Society of Rural Physicians in Canada, which is excellent healthcare close to home for all rural Canadians. And looking at it from that perspective, then access, of course, can interfere with that in a variety of ways, including access to excellent care, because the excellent care is somewhere else, access to physicians in general or other healthcare providers, difficulties with transportation, care that's provided distantly that could be provided home through the use of either extenders of physician extenders and such in the community, or healthcare providers coming from a larger center. So for instance, in BC, it's a NEDOP program which allows specialists to visit rural communities and provide specialist care in the rural communities. The other challenge related to specialist services, things like physiotherapy and occupational therapy, speech therapy, social work, and such like that. In smaller communities, these services are not available, and it's very challenging for some patients to get a connection to them. There's a variety of ways of improving that. One is, of course, simply to use virtual care provided via video conferencing or internet or what have you. The other aspect of care, of course, is access to healthcare providers. What we value in healthcare is particularly in primary care, is longitudinal relationships and a broad scope of practice. This is what's important for healthcare in rural areas. And sometimes this is difficult because of the shortage of physicians, shortage of other healthcare providers, but not only a shortage, a rapid turnover. So when a patient has to establish a relationship with a healthcare provider and is comfortable in discussing their healthcare issues, and the provider then moves on somewhere else, this is quite challenging to develop a relationship with a new provider. When we look at this in a larger context, there's a real shortage of physicians that are willing and able to practice in rural areas. We spent some time today discussing how we can improve the production of physicians, but also other healthcare providers that were keen to go to rural areas and able to practice to the full scope of their skill set. And there's such things as encouraging rural students to go on to higher education, to encourage and support rural people in going to medical school and going and doing family practice residencies and specific rural training. We recognize the importance of careful selection of our medical students so that they're fit for that purpose, fit to go to be a generalist and able to practice in that setting, but not only able, but also enthusiastic to work in a rural community. There's so many aspects of how we encourage people to do that. And the most important one is training in those settings. And so, in so much as how we select students in our training programs and where we train them is of vital importance if we're going to continue to have adequate numbers of healthcare providers in rural communities. In the absence of large numbers of particularly physicians, then we truly need to be working in a team fashion so that everyone is working to the full scope of their practice, that patients know where to go, that all doors lead to the same place, in the sense that when we talk about patient medical homes, we're really talking about a setting where all patients know this is where they get their medical care, this is how they get their medical care, whether that care is being provided by a nurse or a nurse practitioner or a physician or a social worker. That care is all provided in a place that they recognize and it's connected, and they don't need to have difficulty finding out where to go and when to go.
Again, I think with things like the patient transport network and, I think they've made some great changes, including having nurses that help with kind of that clinical decision making. And they also tend to have a bit more awareness of the geography of the province, which is great. But I think, we need to do more and do better, and we need to have more access to emergency like transport vehicles like planes and helicopters and different things, so that it doesn't matter if we have one critical case in the province or 10, but we can get them out if it's deemed that is absolutely necessary and needs to be done as soon as possible. So we need to improve our partnerships with other services and agencies so that we can have access to those vehicles when we need them. We also need better trained paramedics to be able to man those crews, so that the only nurse in the community doesn't have to transport out with a critically ill person. So I think those things are really important in this area. I also think that we need to increase the understanding of people from more urban centers and rural areas. So back and forth. So I think rural physicians and other providers need to understand the context in urban environments and what they're dealing with, but even more so, I think the urban areas and specialists and that need to understand what it's like to work in Nelson or Fort St. John or Smithers, and I think the best way to do that is to have them physically go, even if it's just one time, but so that they can see how remote, they can see the emerge room, they can see what kind of resources we have and what kind of resources we don't, so that when I'm stressed to the max because I have a critically ill infant or other patient and I'm calling somebody in Vancouver and they ask me to call in the pediatrician on call, that I don't have to waste time explaining that they don't exist, that I am the only one there. And so I think by helping to foster those relationships and help build understanding of context, I think that when I call, it can just go so much smoother, so that we don't have to hash out things that are pointless and just waste time when I have somebody who really, really needs urgent care.
I'm a rural family physician, a generalist physician, a technology-enabled generalist physician, and I'm also a health services researcher. I believe that the advocacy that we do can be strengthened remarkably by focusing more on the evidence that underpins the advocacy. The positions we take should be increasingly evidence-based, and that will support better policy. This aligns well with what the ministry is doing in moving towards a more evidence-based and research-based culture, and I think that it's an opportunity for us to move forward. I think that much of what we do currently is based on instinct, based on common sense, and mostly works. Rural, I think, has suffered over the years an erosion of services, and it's probably not that anybody's dismantling rural, but rather that it's not being attended to adequately. And I think if we focus on the evidence that underpins rural health services, we can do a better job. And I think I know how we might be able to start. The first few steps in that sequence. I think we need to measure what we're doing. And the way to do that is through creating population catchments around rural communities and looking at the outcomes. And where innovations are working, where the system is working well, will become rapidly apparent. The first step in understanding whether a population is being well served will be looking at the utilization patterns. And if an appropriate part of the population is getting their services locally, and if generally the population is accessing services that make sense for the demographic profile of the population, then that service is probably doing a good job and should be recognized and emulated. If, on the other hand, utilization patterns suggest either selective underservice or inadequate services, then that's a population that should be supported. So utilization, rather than the determinant of services, becomes the first layer of outcomes. This fits into what I would call a framework of natural laws of health services that underpin appropriate and sustainable services for rural communities, and something we don't understand well and should understand much better. We should be able to look at a population, look at its demographic characteristics, look at its the distance from the next community where services could be provided, and we should be able to come up with a service profile that would serve that community. A service profile based on technology-enhanced generalism with adequate access to specialists both locally and away. I think this is a strategy for action that we should adopt and implement, as I think the future will be better and better if we do that.